Today, let's study about fibrous dysplasia, which is one of the bone and joint lesions. It is usually asked for 5 marks. So the first thing is it is mostly uncommon, non-hereditary and developmental anomaly. Its primary defect is that in the name it tells fibrous dysplasia, which means the bone gets replaced by fibrous tissue in which the secondary metaplastic bone formation occurs. The cause of fibrous dysplasia is post-zygotic somatic mutation, that is gene mutation. So the gene is GNAS1 gene, that is guanine nucleotide binding protein, a stimulating activity polypeptide. Now let's look into the pathogenesis of GNAS1 gene. This GNAS1 gene encodes the G protein, where if it gets mutated, it will be a continuous activation of G protein. So there will be two pathways, either increased CAMP or beta catenin signaling mechanism is seen. If beta catenin signaling mechanism is done, so it becomes bone modulation is seen here. If CAMP is increased, then it affects the three parts of the body, that is the endocrine organs, melanocytes and osteoblasts. In endocrine organs, there is hyperfunction which causes a precocious puberty, that is early puberty than the expected age. In melanocytes, there is increased proliferation which gives an appearance that is called cafe au lait spots, which is pigmented macule. This is usually asked for 2 marks. Then if the osteoblastic activity, it forms a defective differentiation, that is fibrous dysplasia, as in the name it tells. Moving on to the clinical features, there are two types, polyostotic and monoostotic type, based on the severity of disease and the tissue. So the name it tells, polyostotic, it affects many bones, and monoostotic, it affects single bone. In the poly, we see 20 to 30% of the cases, which is rare in condition, but in monoostotic, we see 70 to 80%, which is more. But in polyostotic, it is more severe, and whereas monoostotic, it is less severe. And this affects few to most the bones, as I have said before, and here it affects only one bone. Now the site of involvement is femur, tibia, pelvis, ribs, skull, facial bones, upper extremities, lumbar spine, cervical spine and clavicle. This is in the decreased order, whereas in monoostotic the site is rib, femur, tibia, craniofacial bones and humerus. In polyostotic, we can see pain in the bone, but here there is mild predominance of the females in monoostotic. In polyostotic, we see frequent fractures, continuous. We can see many fractures because many bones are involved, bowing of the long bones we can see. And one more feature we can see here is shepherd crook deformity, which is the pathognomonic curvature of the femoral neck and the proximal shaft leads to that characteristic, that is the bowing of the bones we can see, especially the femoral neck. Whereas in monoostotic, we can see, which is most commonly in children and in young adults, when the maxilla and associated bones are affected, we can see leonine appearance, that is like a lion face appearance, that is also called as leontiasis osseae. In fibrous dysplasia, we can see associated syndromes, that is usually with polyostotic, we can see these syndromes. There are 3 syndromes. One is Macular-Albrecht syndrome, which is a triad of polyostotic fibrous dysplasia, endocrine abnormalities, cafe au lait spots. The same Macular-Albrecht syndrome, excluding the endocrine abnormalities, it gives Jeffes type, that is polyostotic fibrous dysplasia and cafe au lait spots. And then third one is Mazabord syndrome, which is polyostotic fibrous dysplasia, and multiple intramuscular myxomas are seen here. Moving on to the oral manifestations, when jaw bones are involved, we can see pain, swelling, deformity of the affected bone, typical malocclusion. Oral manifestation, the first clinical sign is painless swelling or bulging of the jaws. Then fibrous dysplasia of the maxilla is a serious form where the children are affected the most, difficult to eradicate, hence the treatment is radial or multilateral surgery. Facial deformity also is seen, and the lesions are not well circumscribed, extend locally. Radiographical features, we can see radiolucent lesion, which is normal trabecular pattern, is completely lost. Hence, the opacity is given by a normal trabecular pattern. So, the endosteal portion is scalloping, that is like this. You can see the endosteal portion. We can see lucent lesion, that is a sclerotic border which gives a rind sign. Early lesions, unilocular or multilocular radiolucencies can be seen. Mature lesion gives radio-opaque spicules in radiolucency. If this is a radiolucent, behind we can see dots or specks of radio opacity which gives a ground glass appearance or orange peel appearance. Radiographs thickening in the skull bone is characterized finding of the craniofacial fibrous dysplasia. The histopathology we can see when we do is this irregular C-shaped trabecula of the woven bone, like this you can see the woven bones. Then early lesions, we can see fibrous tissue which is in the trabecula which gives an advanced lesion. This advanced lesion is the bony trabecula, forms a Chinese letter pattern, that is C-shaped pattern. Then intertwining of the fibrous connective tissue shows mononuclear cells. The treatment is no specific treatment is required, hence it is self-limiting disease. So monoaesthetic, if it is present, we can give cosmetic surgery because of facial deformities. Then otic canal decompression we can give because the maxilla size increases. We can give vitamin D and bisphosphonates therapy. In polyoaesthetic, we can give multidisciplinary approach addressing multiple bone defects and endocrinal dysfunctions. Radiotherapy is not a choice since risk of development of radiation includes sarcomas because the bone is too fragile here. Thank you.